Before you ever pick up a catheter, it's worth being clear on why you're putting a needle in someone's vein at all. And Roman 4 is not a reflex, it's a decision, and a good medic can say out loud what the line is for before they start it. So this first section is the why. What an Roman 4 line actually does for your patient, what's happening with their body water when they need one, and the clues in your assessment that tell you a line is justified. Get the why solid, and every skill after it has a place to hang. An Roman 4 line does exactly 2 jobs, and almost everything in this course traces back to one of them. The first job is fluid. You can put volume directly into the circulation to support perfusion when the patient is losing it or can't keep up. The second job is access. The line is a door, a fast, reliable route to give medications straight into the bloodstream, where they work in seconds instead of minutes. Caroline defines intravenous therapy simply as cannulating a vein with a catheter to reach the circulation. Fluid in or a route for drugs. When you start a line, you should know which one you're there for. Here's the backdrop. The body is mostly water, and that water is the environment every chemical reaction of life runs in. A healthy person loses roughly 2 to 2.5 liters a day, through urine, through the breath, through the skin, and replaces it by drinking and eating. A well body keeps intake and output in a tight balance. That balance is homeostasis. The ill or injured body often can't. When that balance breaks, fluid ends up in the wrong place or in the wrong amount, and that is the gap and Roman 4 is built to close. Picture the body's water in 3 compartments. Most of it is inside the cells, intracellular. The rest sits outside the cells, extracellular. And that outside water splits again into the fluid between cells, the interstitial space, and the fluid inside the vessels, the intravascular space, your bloodstream. They're connected. When the bloodstream loses volume, the body pulls fluid inward from the interstitial and intracellular spaces to defend it. That borrowing is why a patient can look compensated right up until they suddenly don't. And it's why the vascular compartment is the one your line refills. When total body fluid runs low, that's dehydration, and it shows up in your hands-on assessment, which is the whole point for you. Watch for an altered level of consciousness, a blood pressure that drops when they sit or stand, fast breathing, a fast heart rate, dry mucous membranes, poor skin turgor, less urine and flushed dry skin. The causes are the everyday calls. Vomiting and diarrhea, diabetic emergencies, hemorrhage, heat exposure, simply not drinking enough. None of these findings alone shouts Roman 4, but together they are the picture that makes a line make sense. The opposite problem matters just as much, because your Roman 4 can cause it. When there's too much fluid, it backs up out of the vessels into the tissues. The cardinal sign is edema, and the classic bedside test is pitting edema, where you press the skin and the dent stays. You may also hear crackles in the lungs, see puffy eyelids, shortness of breath, sudden weight gain. Patients with poor kidney function and very young children are the most vulnerable, and an unmonitored line running wide open is a listed cause. The lesson lands early. Fluid is a drug and the dose can be too high. So what's actually in the bag at your level? Isotonic crystalloid, salts dissolved in water at about the same concentration as the body, which is why it spreads through the extracellular space without yanking water across cell membranes. The 2 you'll hang are normal saline, which is 0.9% sodium chloride, and lactated ringers. Crystalloids are the right first choice for prehospital volume replacement, but remember the one thing they cannot do: they carry no oxygen. You're refilling the tank, not replacing blood. Caroline's caution is blunt. Fluid resuscitation should never take precedence over rapid transport. Put it together. When do you reach for a line? When there's volume loss or shock you need to support, when you anticipate the patient will need fluid or drugs en route, or when you need that medication route. At the EMT Roman 4 level, most often a fluid bolus or 10% dextrose for a hypoglycemic patient, and titrate to perfusion, not to a perfect number. In adults the field target is around 90 systolic, unless your protocol says otherwise, because overfilling dilutes the blood that's left and can worsen bleeding. The skill is real, but the judgment of when and how much is what makes you safe. That's the why. Next section, we put it inside your scope of practice and your patient assessment. What an EMT is cleared to do with a line, and how the adult and pediatric exam tells you the line is warranted. Everything you read more on for this section is on screen.